Hi, everyone. My name is Mitali Dave. I'm on the board of CureJM, and I just wanted to thank you all for being here. Today, we've got a great couple of speakers who are spending their Saturday afternoon on a volunteer basis to talk about what we all would love to know, which is understanding tests in juvenile myositis and other signs of flare. Really appreciate you guys being here and doing that. We've got Dr. Bita Arab Shahi and Dr. Laura Tassan, and I'm just going to go ahead and hand it over to them.
Well, thank you for having me. It's really an honor to be present at such a great conference this year that we've been having. So I'm going to talk to you guys about understanding some test results or imaging results that we routinely do in our kids with juvenile myositis to be able to follow their disease course and make decisions about their therapy. And, I was trying to make this talk a couple of weeks ago, and it reminded me of a conversation I had. We were texting with my teenage daughter, and we're going back and forth, and I was asking her a question, and she answers back something like, OMG, IDK, HWQ, or something like that. And I was like, what is she talking about? I had to actually go to Google and use translation devices to figure out what this alphabet soup was that she was texting me. And I was making this talk, and I thought, man, that must be how we sound to you guys, because you come in to see us, and we're like, oh, the AST, ALT, ESR is high, and the CRP is stable, and you might be thinking, what is she talking about? So I'm hoping after this talk, we'll have a little better idea of this kind of alphabet soup and acronyms and synonyms that we use for things, in addition to going over some of the testing in terms of radiographic type testing that we use in juvenile myositis. So before we get into the alphabet soup, I wanted to go over just kind of the anatomy of normal versus inflamed muscles. And I think you may have seen some of this in the earlier talks already today, but I think it's important in terms of understanding specifically muscle enzymes, how they're generated. So you can think of your muscles or your muscle fibers as kind of being pieces of hay that are stacked together, and then you put different stacks of hay together to make this kind of bigger blob of muscle. And if you were to cut this muscle in cross section and then look at it via microscope, this is basically what you would see. You would see these little fibers and muscle fibers in cross section. And they're kind of polygonal looking. They're all about the same size. They kind of fit together somewhat organized manner, like in a puzzle. Versus when you have juvenile dermatomyositis and your immune system is really revved up and it's sending those bad immune soldiers to destroy the muscles, you see all these blue cells all over the place and between the muscles, around your blood vessels, that are causing damage. And then the muscles themselves look different. You can see they take on a more round appearance initially, and then they're like much smaller because they get atrophied, they get damaged. And as they're getting damaged, they are releasing these muscle enzymes. And that's what we're measuring when we check labs. That's like one of the primary things that we like to measure. Now, everybody releases muscle enzymes. You don't have to have dermatomyositis. If you're alive, you have muscle enzymes in your bloodstream that are measurable. But in dermatomyositis, the magnitude of elevation of these muscle enzymes is much higher than you would see in a normal population. So if you were to, for instance, take a marathon runner and at the end of their run, check their muscle enzymes, it would be really high because they've really overworked those muscles. That might be comparable to the muscle enzymes that you see with somebody with dermatomyositis. The difference being in a marathon runner that recovers and it goes back to normal, but with dermatomyositis, that attack is like constantly happening because of the immune system being revved up. So unless that immune system is being suppressed with medications, your enzymes aren't going to come down. So the main muscle enzymes that we tend to screen, because it leaks out into your blood vessels and then we can measure it in your blood, are the aldolase or the creatine kinase or CK, lactate dehydrogenase or LDH, and aspartate aminotransferase or AST. So really big names, hard to pronounce names, so we tend to use the abbreviations like the teenagers who text also. But that's usually hear it referred to as CK, aldolase, LDH, and AST. Those are the main ones that when we do blood work every couple of weeks or every few months, that we're always screening for. Now, these muscle enzymes that are released by the inflamed muscle, they don't all go up and down at the same time. They have kind of different orders in which they rise and they fall. So usually when someone is first diagnosed and has that initial muscle injury or inflammation, the CK is the first one to go up, and then the AST, LDH, and aldolase follow. So for a lot of your children, by the time we see your kids, they've already had myositis for a while because they've seen the dermatologist and they've seen the pediatrician and they've seen maybe the neurologist. And so by the time they come to us, they might actually be here where their CK is not very high, which is why it's really important to look at the more chronic muscle enzymes as well, the AST, LDH, and aldolase. That kind of gives us a little bit of an idea of how long this has been going on. So that's why we check all of those. There are other markers that we check in blood which are less specific. So clearly muscle enzymes are very specific. They're released by your muscles and your muscles are inflamed. But there are other markers that can be elevated, not just in dermatomyositis, but also in dermatomyositis. So the main ones that we look at are the SED rate, or the erythrocyte sedimentation rate, and the CRP, or C-reactive protein. Now, these markers can be increased in anything that causes inflammation. You could have a virus, you could have cancer, you could have anything that causes inflammation, and your SED rate CRP goes up. But in absence of those findings, if your kid is totally healthy, it's just their JDM, they don't have a cold, nothing else is going on, seeing an elevated SED rate CRP might be a marker for their disease flaring. Similarly, there is vascular damage markers. So if you saw in that pathology pictures, you have your muscles and there's a bunch of blood vessels running. So when the muscles get inflamed, there's also inflammation on the lining of the blood vessels. And that can cause the release of something called von Willebrand factor antigen. Again, it's not specific to dermatomyositis. Any condition that damages your blood vessels or causes vasculitis can increase this level. And then there's other things that falsely elevated, like if somebody's on birth control pill, they have estrogen on board, that can increase it. Liver disease can increase it. So again, it's not specific to dermatomyositis, but in absence of other findings, it can be monitored to assess signs of flare. Then the other thing that we sometimes check is, this is not something that we repeatedly check, but it's usually checked when a child is first presenting to our clinic as a new diagnosis, is myositis markers. Myositis markers may not change our immediate acute treatment or management of a patient, but it gives us prognostic information. It gives us information about what do I need to monitor long term, what do I need to worry about in this kid more so than other kids. And the problem is most kids, or a lot of kids, actually don't have any of these markers. So myositis-specific markers are only positive in about 50% of kids with juvenile myositis. So with those kids that don't have the markers, we don't really have a good idea of the prognosis. We just have to see how they do and how they respond to medicine and kind of gauge it that way. But in the 50% who do have some of these markers, that might make us think specifically of certain things to screen. So among the 50% who have the markers, the most common one that we see is anti-P155. The kids who are anti-P155 positive tend to have more issues with sensitivity to sun. They get really bad photosensitive rashes with sun exposure. They have usually kind of moderate to severe weakness when they present. They tend to have a little bit more chronic course, like their disease might be well controlled with medicines, but if you try to wean the medicines, they relapse. So in somebody who's P155 positive, I would have a lower threshold. I would want to keep them on medicines for longer. I wouldn't be too excited to wean them off medicines completely because their relapse rate is a little bit higher. The other group is the anti-MJ group. The anti-MJ group, they may not have as much photosensitivity as the P155 group, but they have more issues with muscle cramps, contractures like bent elbows or knees, and dysphonia, like their voice changes, or calcinosis, and they might have more issues with developing gastrointestinal ulcers in their stomach or elsewhere in their GI system. So somebody who's anti-MJ positive, if they're complaining of recurrent or significant abdominal pain, I might take that more seriously than somebody who doesn't have anti-MJ in terms of doing imaging and making sure there's nothing more serious going on. The third group is the anti-NMDA5 group. This group, again, it's less common to see this in children, but they tend to get a lot of issues with like ulcers under skin, like kind of superficial cutaneous ulcers under hands or different body parts. They tend to have more issues with, more issues with arthritis, and they might have involvement of the lungs, which is not seen with the other groups. And the lung involvement, there's something called interstitial lung disease that we see particularly in MDA5 patients who are of Asian ancestry, in particular Japanese ancestry. So again, that can be helpful to us in terms of monitoring organ systems that we otherwise might not have a high suspicion of involvement with. And then finally, the group that has anti-HMG folate reductase antibodies associated with their disease, these kids tend to be much sicker. They have really severe weakness. They can have a lot of muscle atrophy and contractures. Their CK levels tend to be really, really high. And again, these kids have a much more chronic course of myositis. So we would want to keep them on medicine and not be too excited to wean quickly. So these markers, we don't usually like repeatedly check because they don't change. Once you have those antibodies, you have those antibodies. But it can be helpful at diagnosis if the child has the marker in terms of helping us with prognosis. So moving on from labs to other imaging type tests, and we'll go through each of these individually, but magnetic resonance imaging, or MRI, is commonly used to screen for muscle inflammation. Electromyography, or EMG, is sometimes used. Video fluoroscopy swallowing study is a study that's used to look at the muscles that help you swallow. And I'll show you pictures of that. Pulmonary function test is used to figure out how well you can expand your lungs if the muscles of your respiration are affected. And X-rays, CTs, and ultrasounds can be used depending on what other organs we might suspect as being affected. So MRIs are very commonly used, especially in the beginning when somebody is diagnosed with juvenile myositis, to kind of document muscle inflammation. And dermatomyositis, as you know, is a disease of the proximal muscles. Proximal muscles meaning muscles that are closest to your trunk. And the highest concentration of your proximal muscles is going to be in your like thigh and pelvis area. So usually when we choose an area to MRI, we get an MRI of the thighs. So this is kind of the cross section of the thigh. This is like your femur bone in your thigh and the muscles around it, and then the fat and skin around it. So what we're looking for in these MRIs are like these white areas where the inflammation has caused fluid leakage out of the muscles, or edema as we call it. And the muscle might look atrophied or smaller. Because when dermatomyositis, it's not like every single muscle is inflamed. It's a patchy process. So an MRI will help us determine if they have muscle inflammation and where that muscle inflammation is. And the reason it's good to know exactly where the muscle inflammation is some of these kids need to get a biopsy done. So if a child with dermatomyositis comes in and they're very classic textbook, they have the rash, they have the muscle enzymes, they have the weakness, we don't have to do a biopsy on them. But if somebody comes in and they didn't like read the textbook, a lot of kids don't, and they come in and their rash looks kind of weird, it doesn't quite look classic, or their muscle enzymes aren't quite high, and we need some more information to make sure that this is dermatomyositis. This is not like a neuromuscular disease or a drug-induced phenomenon. That's when we might think about doing a biopsy. And when we do the biopsy, we always do the MRI before, so that we don't just blindly go in and take a piece of muscle out, because we might get some normal muscle if we go in here, for instance. We have to make sure that we go in an area where that muscle edema or inflammation is apparent on the MRI, so that we'll have better yield for our results. And this is usually done by a surgeon under general anesthesia, but the MRI can guide that for them. Another area that sometimes is biopsied is the skin. This is usually under local anesthesia. And this is to help, again, distinguish the rash of JDM. If it's not a classic rash, it can help distinguish like a Gottron's papule from psoriasis or eczema or something else that can look very similar to it. Electromyography or EMG, it's not really that commonly done in kids because it really hurts. So what they do is they stick these two needles in your muscle, they're electrodes, and then they run electricity between them. Like, who thought of that, right? To see to see like how the waves are. They kind of measure how fast the nerves can send electrical signals in the muscle, and the way they peak and flow, the way this kind of graph looks that they get, can help predict or can help show what kind of myositis the child has. If it's dermatomyositis, it might have a different look than if it's like a neuromuscular type disease. So again, EMGs we might consider if we really aren't sure it's dermatomyositis and we don't have other studies and we're still not sure, we might rely on that. It's used more in adults and it's used more by neurologists, but it is an option that's sometimes used to help diagnose JDM. A video fluoroscopy swallowing study is a common study that we do at onset of disease as we're trying to figure out how extensive someone's dermatomyositis might be to determine how aggressive to be with their treatment. And then sometimes later on, if they have flares, we might repeat this. And basically what this study is when you go to a radiology suite and they use fluoroscopy. Fluoroscopy means they have it's almost like having a bunch of x-rays right after each other. Boom, 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 boom. So you can kind of follow, and it's almost like a video made of x-rays. And so with the fluoroscopy, what we're looking is as the child swallows barium, this black stuff, how is it moving down the throat? So initially they give the barium as like a thin liquid and they look and see, okay, are the muscles working okay? Is it going down okay? It's not getting stuck. And then they give the barium in like a paste form, so it's a little bit thicker. Then they put the barium on like a cookie or a cracker and you eat it, so it's going down as a solid. And they compare and see, are the muscles that help you swallow working well to push this food down? Because if you have weakness in those muscles, then you're at risk of choking, you're at risk of aspiration. We have to be much more aggressive about treating. Another test that your children may have had is a pulmonary function test. Again, we do this at the onset of diagnosis to determine extent of disease, whether the muscles around their lungs or diaphragm is affected by this. Because, again, that's a very serious thing if you have that affected in terms of breathing and getting enough oxygen to your body. So what the child does is they blow in this tube, and the information from how forcefully you can blow is transmitted to this computer that generates a graph. And then the graph tells us if the child has restrictive or obstructive disease. Obstructive disease is like asthma, like when your bronchioles and airways are tight. But that's not what we're so interested in. We're more interested in restrictive disease, which tells us how well are your muscles working to let you inhale and exhale. So when they blow really, really fast in this tube, they can kind of actually measure the lung volumes that way. And it can measure the maximum kind of pressure with which you can inspire and expire. And that helps us determine if the muscles used for breathing are working well enough. Another thing that a pulmonary function test can help with is a diffusion capacity, which is how well oxygen can travel from the air in your lungs into your blood vessels to get into your body. So you can imagine, like, in the Three Little Pigs scenario, if the wolf had restrictive disease, he would not be able to blow away that wooden or hay house. And so that you can kind of think of that as how a pulmonary function test, something that it would measure. So these other studies are kind of like optional studies. We only use them depending on the specific situation that the child might be in. So we mentioned like there's a subtype of dermatomyositis where they might have lung involvement. In that case, we might consider doing a CT to look for interstitial lung disease. Or sometimes if we're suspecting abdominal involvement or arthritis, we can use ultrasound. There was an excellent study published by her, or there was a poster downstairs about using ultrasound to look at muscle inflammation, and we're really hoping that that will be a much more popular, because much less expensive study to be able to monitor myositis. Echocardiogram and EKG can be used if we suspect cardiac involvement. This is not very common in dermatomyositis, but in polymyositis, particularly in African American children, the heart can be involved, so we might want to screen them serially with echocardiograms or EKGs. And then x-rays are often done if we're suspecting calcinosis. And this is, I don't know if you can see very well, but these like little sheets of calcium can be seen in the muscle and under the skin of this child with calcinosis. So why is laboratory and procedural testing important? Well, these are kind of like our magic toolbox. This is how we figure out how extensive somebody's dermatomyositis is. Based on that, how aggressive do we need to be in terms of starting their therapy or maintaining their therapy. If the child is positive for one of those myositis markers, it gives us prognostic information, because there might be a particular organ system that we may not think of, but in that patient, we need to follow that more closely, like the lungs or the gut. It also gives us markers to follow up, like the muscle enzymes, to be able to taper those evil steroids. That's why you get labs done every 2 weeks or 4 weeks or 6 weeks, so that we can call you on the phone, hopefully, and say, your muscle enzymes are down. You can go down a little bit on your prednisone, or to add therapy if needed. And it also gives us a way to monitor patients who are already in remission, either remission on medicine or remission off medicines. If they're getting their regular labs done and we're looking at their muscle enzymes over time, usually the muscle enzyme peaks before they start feeling really weak and rashy, and we can hopefully start treatments and pick up on flares earlier, so that we don't have to use quite as much steroids or as intense a therapy as we had to first time around as when they were diagnosed. So with that, I'm going to turn it over to Dr. Tassan to talk about clinical signs of flare, and then we'll open it up to questions.
All right. Well, hello, everyone. I am Dr. Lara Tassan. As of 2 days ago, I graduated from the University of Pittsburgh, completing my rheumatology fellowship. So this is an exciting month for me as well. So I'm very happy and honored to be able to be here, and I'll be discussing signs of a flare. And so I think one big thing is that not one child is going to act the same with everyone else. So your child is going to be completely different than the person sitting next to you when it comes time to them showing signs for a flare. So this is really just a general overview. And again, just understanding that not everyone's going to be behaving the same way. And so looking at general complaints, fatigue. Fatigue is probably the biggest thing that we'll be aware of when children are getting ready to flare. And this isn't just that fatigue that they're waking up and they want to sleep in a little bit more. This is more that when you're food shopping or you're trying to run your actual errands, that child needs to take more breaks and not really be able to do those activities that they used to be able to do with no problem before. And so some of that fatigue can come because of the muscle weakness, but sometimes it may just be there even without those muscles actually being involved. Fevers are something that we see as well, and this isn't just the 100-degree fever. This is more like the 101, 102, 103 without having any other signs of ear infection or strep throat or any other reasons to be having that fever. Enlarged lymph nodes, and that can be along the throat, under the arms, in the groin region. Obviously, we know that the muscles can be involved, and as we had mentioned before, it's the proximal muscles. And so as disease has been there for longer, those muscles can evolve to being affected more in the lower part of the legs, the lower part of the arms. And so with that weakness, kids can be tripping more, having problems getting off the floor, lifting their arms, be able to wash their hair when they're in the shower. So again, doing things that before they had no problems doing, but now all of a sudden this is a change. And with that can come more behavioral changes in the sense of them becoming more frustrated, irritable, angry, because they know that something's wrong. So it's you guys being able to pick up and knowing when things are different. And sometimes it's even the child bringing it to your attention and just saying, Mom, this doesn't feel right. This is a change. And again, with that, the weakness, more of the falling episodes and tripping too. Actual joint pain, so joints can become involved with them being swollen and warm, having more stiffness in the morning. And so we can definitely see arthritis being a sign of a flare. And so when it comes to skin, these are some of the terms that you guys have probably already heard by now maybe. But these are more of the classic findings that we would see. And obviously not every child is going to have everyone that's listed here, but I'll be showing more pictures as I go on that way. I'll talk more in depth about them later on. When it comes to the stomach, kids can have abdominal pain, and this again isn't just the timing around the methotrexate. This is more that persistent pain, and sometimes with that can be more of weight loss, blood in their stool. They're not able to absorb food well enough, and that's going to be one of the main reasons why you're having weight loss, not because of them just not wanting to eat and having a decrease in their actual appetite. And so when we know their actual antibodies, when we're seeing a child that maybe has an anti-MJ antibody and they're also having more abdominal pain, again, that's going to alert us that this is something that we need to look into and screen with different imaging a little bit more versus just saying, oh, it's constipation, just drink more water and you'll be fine. And again, knowing that the muscles around the throat can become involved. So kids can have more of that choking, needing to drink more water when they're trying to eat a bagel, kind of the throat clearing. Their voice can change, having more of kind of that a nasally, high-pitched voice. And again, getting back to the stomach involvement, blood in the stool can be something that we can see. But this isn't just you wake up and you're having these. This is more of a progressive. This is more going on for weeks. A lot of these symptoms are same symptoms that you can see if you have the flu, a strep throat, a virus, any other infection too, or another autoimmune disease. So it's really seeing the progression of that complaint and how things have changed over time. And then that's when it's really kind of based on you guys keeping a diary and then alerting us and making sure that we're aware of this and knowing that it is a change and then making the decision of how we need to work it up at that time. But the skin is probably the most specific when it comes to a flare, and obviously it's a great way for you guys to be able to see, and then we can see it too, but it's kind of that way of having like a window into what's going on in the inside of the body. And so Gottron's papules are more of those flat-topped wart-like structures that can be on the tops of the hands, the knuckles, the elbows, the knees, even around the toes. And so a lot of times people might think these are actually warts that they've been following with their actual dermatologist for and might have failed treatment for years, and then finally they do a biopsy, and then lo and behold, it's not a wart. It's something that we would treat completely differently. And so these are ones that you would be monitoring for if they're erupting. With that, you can also have, or even without that, the small little vessels, the capillaries that are around the nail bed. And so we know that in juvenile myositis, these small blood vessels are the ones that become inflamed. And so it's kind of an easy way just to look at the nails and to see what those blood vessels actually look like. And sometimes if the inflammation is really bad, you don't need an actual instrument or a microscope to actually look at them. You can just see them with your naked eye. Other times putting a little bit of gel on to help magnify it, and looking under the same type of instrument you would look into the eyes with, you're able to actually magnify those blood vessels. And here's some more images of it. So this is, again, another way that you can see those blood vessels that are around the nails. They can be around the gums, around the intestines. Other ways to see the inflammation and to see how angry that they look. And you can see even the comparison here that these are more prominent, they're more thicker, they're more dilated, and they're not lining up like a picket fence. Whereas in somebody that didn't have the inflammation affecting those blood vessels, you wouldn't be able to see them. Gottron sign, some people use papules and sign a little bit interchangeably, but the sign is more of the kind of the scale-like features that you can see more on the elbows and the knees. A lot of times this gets mistaken for eczema or psoriasis, and so you can see that they can become pretty raw looking, and a lot of times there can be some itching associated with it too. And so the V sign or the shawl sign we can see on the back. So the V sign's more on the front, and shawl sign's the kind of redness on the back. And on his arm, we call this linear erythema, so just that streak of redness down the arm. And if this was a patient that you didn't know that had juvenile myositis, you would say, oh, you were just in the sun, you just had a sunburn, no big deal. But knowing this patient and knowing that they do have this, and that this has been getting worse over time, over 2 to 3 weeks, it's getting more red and he's not being out in the sun, then that's going to be a clue to that this is a flare, not just him getting a little extra color. Malar rashes and heliotrope rashes. So malar rashes are ones that we can see in other autoimmune conditions. It's more the pinkiness, redness on the cheeks. It can be on the forehead as well. Heliotrope is more that purple kind of dusky color that can be covering the eyelids. Sometimes people mistake it for them actually wearing like blue eyeshadow. But you can see that the little small blood vessels, you can actually see them at the base of the eyelids as well. So when there is a lot of inflammation, that's what you're actually looking at, is seeing how inflamed that area is, and they can actually ulcerate and crust too. And so the blood vessels can become inflamed around the gums as well. And so in this patient, you can see that obviously his gums are not so happy, that they're red and angry. And actually his little blood vessels around here are so inflamed that they've caused ulcers in the actual skin. And so, again, getting back to that, this is not just you're waking up and all of a sudden there's a new finding. It's seeing how that has changed over time. Skin is a little different. Skin is more that it's more keeping an eye and seeing, is that something that's just a little bit pinky, or is that now an evolving Gottrons, or on the face, is that now an evolving malar rash? So the skin is a little bit easier to say that yes or no, whereas the fatigue, the stomach ache is always tricky. And so the best thing is just to have more time just to see how that has changed. Is it only happening around when they're getting methotrexate, or is it happening without that? And then being in touch with us, being in touch with the actual pediatrician as well. And then we can make the decision if we need to see you in the clinic, if we need to get labs, if we need to get imaging, if at that point we need to work up other infections, or actually doing an actual biopsy of the muscle to be able to confirm that there is no inflammation there, or if there is. So let us do the ones to worry. You guys already have. We already know at this point that your child has JM. So let us make the decision. Is this a flare? Is this something that we need to work up and screen and treat differently, or get more studies for? This is not where you guys need to hit your head against the wall. That was already done in the very beginning when you didn't know what that actual diagnosis is. Now that we do, we're able to screen and monitor and look for things that we wouldn't have in the past. And so ways that we can prevent it, we know that sunscreen is going to help prevent flares. That sun is 100% a trigger. And so I think we all do a very bad job of wearing sunscreen. I know I personally still have the same bottle from last year, and it's under my kitchen or my sink, but we really need to be applying sunscreen every 2 hours, at least a golf ball size, and that's 30 milliliters. So if you just look at a standard bottle of sunscreen, it's about 230 milliliters. So if you're going to the beach and you're out there for 7 hours and you're reapplying every 2 hours, you should be done that bottle. And I'm sure some of you too still have the same bottle that you've been using, a little bit here, a little bit there, but I don't think we're at all applying it how it should. There's also newer things like SunGuard that is a product that you can actually put in the wash, and it can add sunscreen to basically your clothing. And so you don't need to buy the sunscreen that's going to have the crazy SPF in it. It just needs to be 30 and above. So yeah, sunscreen. Also, we know that when you are sick with an infection, your immune system is going to be revved up, and it's going to be trying to fight that infection. And at times that it can remain revved up, and then that can also cause an actual flare. So it's trying to, do the hand washing, not being around other people that are sick, doing your best for them not to get the flu and not be exposed to extra viruses. Because if we can try to keep their immune system a little bit more quiet, which is what our medicines do, then that's overall going to help them. And then obviously being compliant with medicines, checking in with a rheumatologist. But even with all of this, you could have a kid that's lathered in sunscreen, never even looks at the sunlight, is in a plastic bubble, and they may just flare. And there's nothing that you can do about that. And I know that's probably the hardest thing to hear, is that you're waiting for them to kind of be that ticking time bomb, just ready, to explode and erupt and have a flare. And again, it's letting us do that worrying, not you. We already know, have already done the diagnosis. That was the hard part for you. Let us figure this part out. So again, don't panic, monitor the symptoms. We need to make sure that it's not a virus or there's not something else that if we were to change our medicines, we may, make things worse. And then just be in contact with us. And again, let us be the ones to make the decisions and figure out what we need to do from there. All right, we're going to open this up for questions. From when we did this presentation before, we had a lot of personal questions. So I think what we've decided to do, since this is videotaped, is we will answer the questions of the people that are watching now. And then, no?
Or if you have general questions,
Oh.
and then people are watching.
Oh, there's no online questions? Okay. Well then, thank you everyone watching. We will close. Okay, goodbye.